So I'd like to introduce today's speaker, Dr. Gordon Horn, for COVID-19 neurocognitive and psychological effects. Dr. Horn serves as one of the National Directors of Analytics and Clinical Outcomes for Neurorestorative and is the co-chair of Neurorestorative Research Institute. Before working in National Outcomes, he was the Clinical State Director for Neurorestorative in Florida. Prior to Neurorestorative, he was the Director of Programs and Clinical Services for an independent post-hospital rehabilitation company overseeing multiple programs in both Florida and Michigan. He is a licensed neuropsychologist since 1996, providing care across the acute neurological continuum, including neurotrauma, neurologic ICU and critical care behavioral management, hospital neuroscience programming, inpatient and outpatient neurorehabilitation, and post-hospital neurorehabilitation for the neurologically injured. Welcome, Dr. Horn.
Great, thank you, Doreen, I appreciate it. All right, we're gonna make sure that I can flip my screen here and then we can get started. We're gonna talk about COVID-19. Doreen, you all can see the screen, correct? I hope, yes?
The share screen?
Yes. Oh, hang on for a second, sorry.
No worries.
I forgot to share first. There we go.
There we go.
All right, now hopefully we'll get it into slide mode. Does it look like it's in slide mode? All right, very good. So we're going to talk about COVID-19, and I know, at first people think COVID-19, well, how's this related to anything to do with neurocognition and neurorehab and really brain injury? Well, the simple answer is actually quite a bit. And so what we're really going to talk about are the effects of COVID, and we're going to spend a lot of time on not only the neurocognitive effects, but also the psychological effects as well. As I have the objectives up on the screen, I'm going to tell you about two patients in particular. And the reason why I'm going to tell you about them is because these are cases that are really very unusual, and it explains really the emphasis of COVID. So case number one was an individual that was actually referred to me 18 months post-COVID exposure. And this is a person who spent 90 days in the hospital. The first approximately 45 days were in the ICU. So this was a person who was unbelievably sick and almost didn't make it. And needless to say, what happened was there were actually two effects of this person's case history. The first is that the person developed post-COVID cognitive impairment, and that is something that I evaluated her for, and it's something that she is actually continuing to undergo treatment for. The second is that she actually developed post-traumatic stress disorder also at the same time. And you would think, my gosh, how could you actually develop both at the same time? Well, the simple answer is this. Her neurologic impairment actually occurred within the first 30 days. And it had to do with the issues of oxygenation, but more importantly is in her MRIs. They did an MRI of the brain during her ICU stay, and lo and behold found that she had multiple strokes, so multiple embolic strokes. And so it was very clear that she was having both neurologic as well as respiratory issues related to COVID. The post-traumatic stress disorder actually occurred as she was waking up, because when she woke up, she was in the ICU, and this was in the heart of COVID exposure. And so this is right at the time in 2020 where really people didn't have a good understanding of what we were doing and how to control things. So she was in an ICU bed, and she was kind of tucked in, as it were, and there were no personnel around because they had to keep everybody in isolation. So when she first woke up, there was nobody there, and so she panicked. And one of the things that also happened was she realized in her panic that she was still ventilated. So she had a tube down her throat. She's laying in bed. She can't move because she's been in bed now for over 30 days. And she also can't respond to anybody or ask for help. Thankfully, she actually was monitored. And so, of course, the nursing came in right away and things progressed from there. But even 18 months after the event, her post-traumatic stress disorder was just as significant, and her neurologic issues were just as significant. Case number two, which is really fascinating, is this is with a police officer of all things. And what happened was this particular police officer, she's a 29-year-old female, was in perfect health. And during one of her arrests, the person that she and her partner were arresting was COVID positive, didn't know it until he was actually in the jail when they tested him. And in fact, he was COVID positive, and both she and her partner then contracted COVID. So this was in December of 2020. And so she went through, and of course she had severe respiratory issues. And so that was kind of the thinking, was that, okay, well, this is mostly respiratory, not a big deal. Well, it turns out that it was a big deal, because months went by and she was still having problems, not only with respiratory issues, but she was having problems in terms of coping, but also she was noticing that her cognitive processing was not nearly as sharp. So she inquired about the fact of, getting evaluated. So I had evaluated her approximately 6 months after her initial exposure to COVID. And when I saw her right away, I knew that she had neurologic impairment. This was even before testing, because one of the things that she failed in my examination was a vestibular exam. And in failing that, I knew right away that we were then dealing with much more than respiratory issues and fatigue. She then unfortunately was exposed again to COVID, but this time the Delta variant. And this was in the August of 2021, and wound up having a second exposure, which then exacerbated the first exposure, which then increased all of the issues and increased the neurology of things. And then approximately 3 months later, she wound up being in a car accident on duty, and she wound up having a very mild concussion. But of course, mild is all relative, especially in relation to the fact that she's already got neurologic impairment secondary to having 2 COVID exposures. So as you can see, this COVID isn't just COVID, and it's not just a respiratory issue, but in fact, it can become very complicated very fast. And so these are really kind of 2 good examples of some of the complexities of what we're actually dealing with. And now I'm going to kind of circle back around so that we can really now understand the basis of this. Just so you know as well, the officer that I was referring to, at approximately 1 year from the time of the initial exposure, finally, I was able to get people to do an MRI of the brain, which nobody would do up until then. And we got an MRI of the brain, and sure enough, she also had embolic strokes, multiple mini strokes within her parietal lobe. And again, she was neurologically healthy prior to all of this. So we know that it is in fact causally related to COVID. We also know that strokes, hemorrhage, as well as ischemic type strokes, are one of the side effects of actually having COVID. And we also know that blood clots generally, not only for the brain, but also in other parts of the body, can also be a side effect of COVID, and can be a side effect for high-risk patients with vaccination. So as you can see, something that looked kind of unusual now all of a sudden becomes this very overwhelming condition. So we're going to talk about all of these things. And so that's really the cases that I just gave you is exactly what the objectives are for today. So a couple of things just as an update. So keep in mind that our data continues to update since 2020. And so what I did was I pulled some recent information. And so let me kind of review that real quick. We know that overall, this is a respiratory issue. However, the respiratory issue then triggers an immune response. And in that immune response, it may actually cause immune compromise. In addition to that, what then happens is it causes cell death. And in the process of cell death, it can then damage multiple organ systems, not just the brain, but kidney, heart, brain, lungs are the primary organ systems that actually can be most impacted by COVID. Also, what happens psychologically is that symptoms can range from very mild to very severe. And the difficulty is that at the beginning of COVID, we really didn't have a good understanding of, number one, who would contract it, and number two, what would be the overall effect of that contraction. So we didn't know if you were going to have a mild effect where it was like a cold, or if you were going to have something severe where you wind up on a ventilator. And so because of that, it created fear. And fear was the overwhelming emotion that all of us were experiencing through the rest of 2020, starting in March of 2020 when the country shut down, all the way through until January of 2021. And even at that point in time, we had only had the exposure of the first variant of COVID, but we didn't know what was coming next. So we continued to then build on that fear, and we continued to build on isolation. It was reported that about 73% of healthcare workers were actually experiencing post-traumatic stress. And this is something that we see in almost all major medical outbreaks where something occurs and we have no control over this. The amazing thing is, before COVID, with other medical outbreaks, approximately 10 to 40% continue to have symptoms in 1 to 3 years following whatever that outbreak was. Now, keep in mind where we are today. We're exactly 2 years from the time the country shut down for COVID. And in that 2-year time, we've gone through 3 variants. We went through the original variant, Delta variant, and then the Omicron. And what was different about all 3 was this. The first variant, we had no idea what to expect. We knew that people were getting sick. We knew that it was spreading like wildfire, and that was about it. We didn't know exactly what to do. We didn't know how to do it. And we didn't really know how to isolate other than isolating like you do in infectious disease. The Delta variant was more severe. However, there were 2 things that we learned. Number one is that it wasn't actually quite as transmissible, and people who had been vaccinated to that point seemed to have a certain susceptibility to not getting COVID. And if they did get COVID, then the symptoms tended to be very mild. And it was at that point that we actually started to realize that what the vaccinations were doing generally is that it was helping to keep people away from the hospitals. So instead of everybody getting COVID and then rushing to the hospital, what we were finding was approximately at that point in time, 85 to 90% of those persons that were coming into the hospital were persons that had been unvaccinated. The other roughly 15% were those who had been vaccinated at least once, and they were showing enough symptoms that their respiratory status was questionable. However, those who had been vaccinated were actually discharged much quicker than those who were not. In the Omicron variant, this is what happened. In Omicron, it was much more transmissible. So this was transmitting at a rate of 2 to 3 times what Delta was doing. So in other words, it was easier to come in contact and then contract and then have symptoms right away. However, the symptoms tended to be more mild. And what was interesting at the hospital level is that we were seeing that 100% of persons that were in the hospital were ones who had had no vaccination, and 0% were who had been vaccinated were actually coming to the hospital for treatment. So what it did show you is that actually the smart thing was the vaccination issue, realizing that not everybody can always tolerate a vaccine. So in the event that you can't, then that means you want to take precautions, which is now what you see in front of you. And in these precautions, it's things like this. If at all you ever feel like you do have COVID, take your temperature, because a typical virus is going to give you a low-grade fever, meaning anywhere from 99 to about 101. And so once you have any kind of a fever, then you can assume that you have something that is infectious at that point in time. And if it stays in that lower grade, typically is more viral. Number 2 is, if at all in doubt, wear a mask. We know that from the beginning of COVID, 80% protection, meaning we were reducing the spread by 80% just by simply wearing a mask. And the mask was in protection of others, not just ourselves. So in other words, this was protecting other people from having any kind of bodily fluid or any kind of an airborne transmission, because the mask was then keeping it contained. Also, if you are one of the persons who's in a vulnerable population, then minimizing the exposure. So in other words, don't go out into heavy crowds. And even now, if you're going to be around crowds, probably better to be outside than necessarily inside, unless you know that the air is well filtrated. And as we knew from the beginning, and we still know today, the typical incubation period from the time of exposure is still 5 to 9 days, Although now we are with Omicron, we were seeing people actually demonstrating symptoms within 24 to 48 hours of that time of exposure. So we do know that Omicron seemed to have a much quicker response in terms of the incubation. Now, this is also, I find very interesting. So this is looking at statistics from 2020, 2021, and 2022. And on this slide, what we're looking at is the World Health statistics. And if you look in September of 2020, so we were approximately almost 5 months into the disease process, we were at 31 million across the world were confirmed. By February of 2021, so approximately 6 months later, we were at 110 million who were confirmed. And by 3 of 2022, which literally I took the statistic yesterday to make sure that I had the most up to date, worldwide is 482 million persons plus have actually been confirmed exposed to COVID and contraction. Now, also in March of 2022, the confirmed deaths across the world is a little over 6 million. Now, 6 million people, that's a lot of people. And one of the things that we learned is that this spreads really incredibly fast. However, if you actually do the math, then that 6 million, we're still at a very low, quote unquote, fatality rate. Now, low is all relative because, again, any person who perishes from this disease and from this process, it's unfortunate. When we look at the United States, back in 2020, we were confirmed at 27 million, and now today we're confirmed at 80 million. And US deaths back in September of 2020 were 491,000, and now we are just shy of 1 million in terms of total deaths from the United States. So the relative populations are showing us kind of the same thing. And keep in mind that COVID has many strands. And so this is not the only time that not only have we not seen COVID, but it's not the only time that we're going to see COVID. Likely it's going to be around with us for quite some time. Now, a couple of clinical things real quick, and I'm not going to really belabor this because we've been dealing with this disease process for 2 years. And I really want to get into more the neurology and the psychology of it. But just quickly, some of the acute symptoms include fever, headache, sore throat. Those are probably the 3 major ones, followed by cough, fatigue, and myalgia or muscle pain. And if you think about it, isn't this very similar to when you get a flu or when you get a really bad cold? Chronic symptoms are more than pneumonia, respiratory failure, or what's called SARS, which is severe acute respiratory syndrome, hypoxia and anoxia, and neurologic impairment. Back in 2021, we had the estimated rate of approximately 29% of those who were COVID positive may experience neurologic symptoms. That rate actually went up a little bit. So now we're saying the range is between 29 to 36% of cases may then have some form of neurologic impairment. Now that could be something like not being able to smell or not being able to taste, or it may be cognitive issues like poor attention span or difficulties in terms of processing. Now, also from the CDC, and this is back again starting in 2020, when symptoms occur, they typically run a range of about 2 to 14 days total. And again, the symptoms may occur anytime after about the 2nd day, as long as up to about 14 days after the initial exposure. That's why if you remember back in 2020 and 2021, you would hear a lot of, if you're going to travel somewhere, you're going to have to isolate for 14 days. Well, that's why, is because the data was showing that there was a total incubation period on the long end of about 14 days after the initial exposure. And of course, we know how volatile this can be. And so you want to stay within that incubation phase. Now it's a little bit different. CDC has actually lightened things up a bit because Omicron was different. What it did was it hit very quick, but it was gone almost just as quick, meaning that you would see it within the 1 to 2 days, sometimes 3, and people were symptomatic anywhere from about 1 to about 5 days. And then the symptoms seemed to be subsiding. Also surprising in healthcare is that healthcare entities started reducing periods of time away from the hospital from 14 to 21 days, all the way down to about 5 days. So once a person was asymptomatic, they could return to work, and it didn't really matter if you took a test for being COVID positive or not. Some of the more significant symptoms are things like difficulties with breathing, having chest pain, confusion, disorientation, difficulty staying awake, also a bluishness in the lips or the face, because what it indicates is you are not oxygenating. Instead, you have too much in the way of carbon and not enough in the way of the oxygen to replace. Anytime you have disorientation, then we know that neurologically there's an issue. Additional signs and symptoms include the loss of taste and loss of smell, and again, lower respiratory illnesses, such as the shortness of breath, lowered oxygen levels, and so on. Less common symptoms tend to be in the GI system, and in the elderly, what was noted is that mental status changes were more fragile and more likely, as well as glucose control. One of the things that we know is that actually COVID can cause an increase in level of glucose, and this is why those who are diabetic have a particular risk factor, is because if glucose can be elevated by COVID and you already have diabetes, then you could substantially cause the diabetes to be out of control. In all of these things that we're going to talk about next, so whether it's in the lungs, whether it's in the other organ systems like liver, brain, or kidneys or heart, is that there's an underlying issue, and it's this. It's called a cytokine storm. And what this means is this. It's a severe inflammatory response that triggers the immune system to then go into hyperdrive. Now, in doing so, in the brain, what it does is it actually causes a problem where the immune system will cause the helper cells to all of the nerve cells to actually then dysfunction. And the longer that the immune system is charged and the longer that we have this storm occurring, then those helper cells begin to then die off. And when they die off, that means that you can't then support the nerve cell. The second issue is that the longer you go without these support cells working and functioning and being present, then eventually the nerve cell will actually begin to die off, or will become so disrupted that it no longer then creates a function. So it's actually not as simple as just saying that I had a stroke. Yes, you may have a stroke, or you may have some other form of a lesion like a hemorrhage, but more importantly is what you can't see is this particular storm where it's causing the cells to dysfunction and eventually causes the nerve cells to dysfunction, which then causes the brain to basically short circuit. And we think that some of this is also happening in some of the other organ systems. In particular, the kidney actually has a lot of anatomy that's very similar to the brain in terms of oxygenation and blood flow. Now, let me show you what this actually looks like. So in the middle, you're going to see this normal brain MRI. And this is just essentially just a gray, looking thing. But you're going to notice that there's variations of gray that go from very, very dark areas that look almost black. And anytime you see that, that means that's actually cerebrospinal fluid. And then you see variations of gray where you have light gray and dark gray. And on this particular brain that's right in the middle, that's actually a healthy brain. So that's about the size that you see, and that's the coloration that you should see. Now, what you then see below it and to the right and to the left of it is actually two different versions of what exactly happens to the brain with COVID and the potential for this to happen in the brain with COVID. On the left, and the slide indicates as an A, you'll see these two arrows, and those arrows are pointing to things that almost look like a quarter-size circle. And what that is both of those are hemorrhaging, and that's hemorrhaging within the temporal lobe. And in particular, this is an area where the hemorrhaging effect is, again, it's within the temporal and also the thalamic region. And these are areas that are very, very rich in blood flow. And so what you then see is that the immune system caused this inflammatory response, and then the vessels basically became leaky, and in which case then you get this hemorrhage. On the right-hand side, this is actually the best way to depict that cytokine storm that I was referring to, where what it does is it causes a mess with the helper cells or the glial cells. And then it causes the nerve cells to then dysfunction because there's nothing to support them. It's kind of like this. It's like building a highway, but instead of putting the crushed stone and aggregate underneath of the blacktop, you just lay the blacktop down. And of course, it's not going to work very well. And in over a very short period of time, that blacktop is going to just break apart because there's nothing to support it. There's nothing to hold it together and to make sure that it works properly. And so that's essentially what happens. And why it looks like kind of like a puff of smoke almost is because what you're seeing is this is the area of the helper cells. And this is the clustering of those helper cells that are actually then dysfunctioning. So it's really been an amazing kind of a neuroanatomy trip when we're really thinking about COVID. And again, I know that everybody thought, well, this is a respiratory issue, and yes, it is, but it's a respiratory issue that leads to a whole host of other things. And if you notice, the key word here is it's a cascading effect, meaning that we have an initial problem that then produces 2, 3, and 4 other problems, and it just seems to kind of keep going. Now, one of the things to keep in mind as well is this, because we just passed 2 years of really dealing with COVID within our country, is that we still are very, very young in terms of understanding the full effects, which means that the research just isn't out there yet. So the research that I've cited in some of this is very early research that came out within the first 6 months of everything happening in this country. And it was really just to try to get information to everybody. So what you see here is this was at the time in 2020, 24 to 25% had central nervous system effects that included headache, dizziness, impaired consciousness, ataxia or a jerkiness to your movement, cerebral vascular disease or stroke, hemorrhaging effect, and seizure effect. Again, back then it was about 24%. Now we're seeing the rate between 29 to 36%. On the peripheral side, this is where we had things like reduced taste, reduced smell. But here's the interesting thing. Taste and smell not only are in the periphery, meaning at the nose and in the tongue, but they have a direct link into what's called the olfactory bulbs, which sit directly behind where your nasal passages are. And so that's actually the direct link into the brain. So we know that taste and smell not only can be at the peripheral level, but it can also be at the central level. And we were using that early on to determine if somebody was at risk for developing neurologic impairment. There can also be a pain response where a person not only has muscle pain and joint pain, but they can actually have what feels like an electricity pain. And again, this is the combination of central and peripheral nervous system. And then there were skeletal symptoms, about 10%, and these would include the myalgias. When you look at altered mental status, what they found very early on in 2019 into 2020 was this. Those who developed delirium, approximately 22% of them then perished from the disease. So this was one of the early markers that we were looking at, especially when patients were in the ICU. Now, of course, if you're in the ICU and you're on a vent, then your mental status is going to be something that you really can't evaluate fully. Now, also the difference between encephalopathy and encephalitis. Encephalitis is an inflammatory response. So this is more of that immune system response that then is causing everything else to become problematic, whereas encephalopathy is a general or global impairment that may be caused from either one or multiple etiologies, meaning there's an underlying problem, but you may not have been able to identify it. So for example, if I have cognitive impairment secondary to COVID, well, that may produce an encephalopathy, which means that I have impairment, I don't think right, I might be disoriented. Now, if I do an MRI scan and I find that I have a hemorrhage, well, now the hemorrhage is the cause of the encephalopathy. But in COVID, if I know that I've been exposed to COVID and the immune system response is being charged, then we know that COVID caused the immune system to disrupt, which caused the storm, which then led to the hemorrhage, which then led to the cognitive impairment. So encephalopathy is a term that indicates the brain's not working right, but it means we don't know the cause at that point in time. So it kind of buys us some time. I'm going to skip over this because we already kind of talked about this in a different way. In terms of brain tissue, like I said, we've kind of talked about this where the tissue itself can become inflamed, and we know that at the cell level, the cells break down. On the neurochemistry side, it's actually a pretty simple concept, and that's this. If my finger is the nerve cell, then I have these helper cells that surround the nerve cell to where you can't see that nerve cell, because the helper cells are making sure that everything is being supported. So I'll kind of give it to you like this. So the helper cells, think of them as holding their hands out, and they give whatever's necessary. So whether that's, food, whether that's, washing the system, whatever. Now what happens is that if in fact these helper cells then go away, now my nerve cell is just kind of hanging out there. And the question is, how long can it sustain itself without having any support? So nerve cells need to be cleaned. And if they're not clean, then they don't function. So what then happens is if this nerve cell, instead of it doing its thing, which is it's electrically discharged, if then what happens is the support cells now are no longer there and the nerve cell can't function, well, now what happens is there is no chemistry, because at the tips of the nerve cells is where the chemistry sits. And in this, what's called the synaptic cleft, which is where two nerve cells are trying to come together, they don't actually touch. Instead, they have a valley where each of them, one will distribute a chemical, the other one will then absorb the chemical. Well, if this nerve cell is no longer being supported, then it's dead. And in which case, then this nerve cell can't get anything. So in other words, it gets no chemistry. If it gets no chemistry, then it can't charge up and then have an electrical discharge to then activate and then cause the next thing to occur. So you can see this is way more complicated than just saying, well, I can't think right. Also, you can get metabolic disturbance, and metabolic disturbance is where the immune system causes disruptions in sodium, potassium, chloride. It may cause a disruption in terms of overall oxygenation, which then changes your red blood cell count, and it might change your white blood cell count, and so on. This white matter disease or subcortical disease, we've already kind of talked about it, but in the white matter of the brain, which is in the core of the brain, astrocytes are these cells that actually help to support everything else. And so in that particular case, in the deep structures of the brain, then the astrocytes are vulnerable to then damage. And of course, we've already talked about stroke, so I'm going to go ahead and bypass that. In terms of cognitive impairment, what we know is this: it's like every other condition, including TBI, which is, the old adage of you've seen one TBI, then you've seen one TBI, because we know that every individual is different. Also in this, every individual's immune system is different in addition to the individuality of the person. So what we can't do is shortcut it. So if a person's having COVID symptoms and they're having cognitive impairment as a result, we don't just do a very simple battery. Instead, we have to do a comprehensive battery because we don't know exactly what's going to be affected. It might be memory. It could be working memory. It could be attention and processing. Or it may be something that's more visual perceptual. It could produce a language impairment, such as aphasia. So again, going into it, we don't know exactly what the full extent of the deficits may be. Just like TBI, we could go from very mild, like what you see in concussion, to then being very severe, like what you would see in the cases that I talked about, especially the woman who was in the ICU for 45 of the 90 days total of being in the hospital. And once again, she is now 18, she's 20 months post-injury, and she still is working on her cognitive functions. So, again, we can't really predict just by looking at the individual. You really do have to investigate it. So like anything else, you investigate it by simply looking at a differential diagnosis. You do a good standard neuro exam, you do a cognitive exam, and you do a psychological exam. And these are some of the tests that, or some of the areas that we actually test. Again, attention, concentration, processing, memory, language, visual perception, executive functions, depression, anxiety. I always test for vestibular findings because there is what's called a central vestibular impairment and there is a peripheral vestibular impairment, and either or both can actually be affected by COVID. My police officer actually had both. She had a central vestibular problem where she constantly felt dizzy, but she also had a peripheral vestibular problem when I actually examined her vestibular system as part of the inner ear. And in doing that, she failed miserably. She actually doing the testing, she actually fell back and landed in one of the couches that I have in my office. So again, thank goodness for the couch. But that's the idea, is that it can be just so diverse. What is also interesting was this, and I tell you, in working in brain injury for a very long period of time, that I really appreciate the feedback that I get from any of the patients that either I have seen or that I may see now. And that is this. I had somebody who I had seen a number of years ago, and they contacted me during COVID. And he said, "You know what, doc?" I said, "What?" And he says, "All I can say is now everybody's experiencing what my life has been like since TBI." And I said, "Well, what do you mean by that?" He said, "Well, we're all isolated." He said, "I've been isolated for years." He said, "I do most things on my own. I try not to disturb anybody. And I find that I still get symptoms, and sometimes I still panic, or I still have anxiety about going out." And he said, "Everything that I keep hearing on the news," he says, "I've been telling people this for years, that this is what those of us who've had a TBI go through. It's the social isolation. It's trying to deal with the isolation. And I will tell you, one of the best things that happened as a result of COVID is that we finally got away from being scared to use this kind of medium to reach out. I have had more patients being seen by this medium of doing video conferencing and video consultations than ever before. And you know what? For people who can't drive, or for people who have some level of disability that prevents them from easily getting to your office, this has been a lifesaver. And not only a lifesaver in terms of being able to provide better access, but lifesaver when it comes to things like anxiety and depression in particular. Because before this time, people were really freaking out about, can we use this medium? And the answer is absolutely we can. And in many professions, this is a good medium to use. Now, when we treat COVID that has neurologic impairment, we do the same thing that we always do, which is neurologic rehab. And what we do is we go through the full court press, starting at the acute level of care. So that may be at the hospital or the inpatient rehab programming, all the way through to post-hospital rehab programs, outpatient, home and community, in-home, you name it. But we use the exact same continuum of care. There's only one thing that we do a little bit different, and that's this. Most patients who've had a very long, a very long set of symptoms with COVID, especially early on, they become deconditioned. And so oftentimes those who are hospital-based, we wind up having to do a fair amount of conditioning first, in addition to then adding on to the neuro rehab. So the deconditioning actually begins in the process of day one of being in the hospital, and we work on conditioning right as a person is then medically stable. We don't wait until they actually get to the rehab unit. However, because of the conditioning issues, you have to keep in mind that the effects of conditioning can last for months. And in which case there is not only a combination of medicines, but also the continuation of therapy services following the acute care model is absolutely necessary to get people to be then at their baseline or at or near their baseline. So again, we do everything the same, except we have to really factor in how do we recondition the individual so that we can decrease fatigue and also decrease pain so that they can then fully participate in therapies. Now, the psychology of things. Some of this now may be very apparent to you all because, again, we've been dealing with this for 2 years. Social isolation, that was number one, followed by hopelessness and helplessness. Now, social isolation, hopelessness, and helplessness, this is not a good combination. This is not a good combination before COVID, and it certainly is not a good combination after COVID because of this. That means that when you have these three things together, you are at a very high risk of not only being clinically depressed, but you are at an extraordinarily high risk of suicide potential. And one of the things that I found during this whole process of using, again, the video medium to be able to reach out to folks is that reducing the suicide potential and the suicide ideology potential was huge by having this form of interaction. Because again, people didn't have to wait for 6 months to go see a provider. They could put in their request and they could be seen typically within a couple of days. And more importantly is this: when a person is suicidal or they have suicidal risk, you don't wait to see them. And more importantly is they don't always need to be seen in the hospital. Instead, having more frequent interaction and more frequent sessions is typically actually more successful at helping to keep the person out of the hospital and then reducing their risk. So there's really been so many things, and I know we focus on all the things that went wrong, but there were a lot of things that went right that are now going to change our healthcare forever in a good way. Psychological distress. And one of the things I'm going to talk about in just a few minutes is this. Do you know that there's a new kind of anxiety that now is erupting 2 years later from COVID? And yes, it's still anxiety related to COVID. I'm going to throw that out there for you because I want you to think about it. And then I'm going to come back to it and give you kind of the answer to that. But it's a new kind of anxiety that we now see 2 years later. Now, there's also a strong condition. And one of the things that we do in the psychiatry world is we talk about it as depression due to a medical condition and anxiety due to a medical condition. The medical condition, of course, being COVID and the diversity of COVID. We also know that mood and neurologic status actually go hand in hand. We know that there is a neurologically based depression and anxiety that can occur, meaning this: a person didn't ever have those particular difficulties, and then when they developed the neurologic impairment, then those difficulties came in, but those difficulties are not related to a person being, woe is me, I'm injured. It's that, no, their mood is not in control, meaning that they'll all of a sudden have a shift in mood, and it could be within seconds, and they have absolutely zero psychological or environmental trigger. Well, that's what we mean by a neurologically based or even a medically based condition that will then trigger anxiety and depression. Now, social distancing, we had to do it. There was really no way around this because it was necessary to then prevent the continued transmission. The downside is that it increased everybody's anxiety. It also increased everybody's anxiety because they didn't know if they were doing it right. We didn't know if 3 feet was okay, 6 feet was okay, or 20 feet was okay. We also didn't know if we were washing our hands correctly. And so what then happened is anxiety started to just blossom. And one of the best ways to deal with anxiety is control what you can. Don't control everything, just control what you can. And what you do is, how you control what you can is this: use safe distance and wash your hands. And so at the time, I was saying this a lot to folks, which is wash your hands, stay distant, wear your mask. Well, when you're at home, make sure you disinfect everything. The idea is, again, exert control where you can. Now, one of the problems with stress over time is that it creates a stress hormone release called cortisol. Cortisol is, in fact, a hormone that is used for our fight or flight mechanism. The longer that we are anxious, the more likely it is that that stress hormone is actually rising. The longer the stress hormone rises, the more damage it actually occurs. What it can do is actually damage the blood vessels from inside out. So what it does is it actually breaks down the lining of vessels. And so when it does that, then you're causing a total disruption. Also, stress hormone causes your brain to be on high, meaning that it's on high alert. And as a result of that, what it will do is it will store energy anywhere it can. Energy is things like sugar, carbohydrates, anything that is really high in kind of that energy. And what it's going to do is it's going to take it and it's going to store it in the fat cells. So you heard people talking about how, oh my gosh, I've gained weight since COVID. Yeah, half of it might have been a change in your eating habits, but the other half of it is just simply a stress response, meaning that as you have less stress, you will then gain less weight. Also, panic was part of this. And one of the things that people were doing was, aside from avoidance and dealing with panic, then they were doing coping kinds of behaviors. One of the coping behaviors was to buy stuff online, because you could do something. The other thing that people were doing was they were buying a lot of alcohol and a lot of alcohol online. I certainly understand it because it's an accessible chemical that will help you to relax in the moment. Just keep in mind, alcohol does not produce a lasting effect. It is simply a short-term effect. And of course, lots of issues with that we won't get into. Now, also, when we look at levels of anxiety and depression, you know, one of the things that later came out was really looking at kids. And kids have really gone through quite a phase. At first, you know, they look to us as the adults. So if we freak out, they freak out. If we don't freak out, they don't freak out. So it's really looking at how do we all get along in the house 24/7. But then as time has gone on, of course, just like with work, everybody got disrupted. Well, school got disrupted as well. And then school became even more disrupted with masks, without masks, who's doing what is the risk, relative risk, so on and so forth. And in the midst of everything, we're expecting our kids to then learn. So unfortunately, in these last 2 years, our learning for the kids who've been in school from first grade all the way through 12th, they've had quite a shift in terms of their learning capacity during those 2 years. Those who've been in college were already used to learning a lot of stuff online, and they were used to accessing things. So they didn't have near the impact. They had some, but not near as what we saw in the elementary and high schools. When we look at controlled studies at the time, what they showed is that people coming into the hospital with COVID versus those without COVID, they found that depression was significantly higher in those patients with COVID. Anxiety was significantly higher than those patients with COVID. Post-traumatic stress disorder was significantly higher in those who had COVID versus those who did not. Again, that's really no surprise. Now we're going to talk about the acute stress and post-traumatic stress. Acute stress disorder and post-traumatic stress disorder, they're the same thing. The difference is this. Acute stress disorder has to be from day 3 to day 30 following a stress response or following a stress. Post-traumatic stress disorder doesn't start until day 31. And essentially what has to happen is we have to have exposure to an actual or real threatening of death, injury, or some level of violation to oneself. So of course, at the early phases, we were watching people die. And we also were noting ourselves that if we became COVID positive, we didn't know how bad was bad going to be. So you have to meet the first criteria, which is exposure to an actual or a threatened death, injury, or violation. And that's why post-traumatic stress and acute stress disorder actually do fit when it comes to the effects of COVID. Again, post-traumatic stress disorder is just simply more significant over a longer period of time. Now, managing. One of the things is to always gain perspective. Stress is based on perception. So what stresses me does not stress you. What stresses you does not stress me. And as a result of that, that means that we have to really kind of keep our perspective in place. So one of the things you've heard me say numerous times today is talking about the issue of control and exerting control when possible. The reason why you want to do that is because that helps you to change your perspective. So for example, I can't control if somebody has COVID and they may be sitting next to me, but I can control if I wear a mask, as an example. I can tell you probably from here on out, I will always fly with a mask. That's my personal opinion. And I will do that because that's one way for me to control that if I'm in an environment that I cannot control, I can control myself within that environment. That's what I mean by perspective. So think about the things that you can do. Don't focus on what you can't do. There's also what we call this triad, and this is where we look at thoughts, feelings, and behaviors. And so if you're stressed by something, what you do is take this and you identify what are you thinking, what are you feeling, and what are you doing. So if I am stressed, that's the feeling. And my thinking is, oh my gosh, I'm in a room full of people that I don't know. I wonder who's sick and wonder who's not. And then the behavior is, am I pacing? Am I walking up and down the aisles? Am I, scratching? Am I doing something? Or if my thoughts and feelings are that negative, is my behavior then making me do something different? Like maybe I'm starting to get agitated, as an example. Then you take this exact same triad and now you look at what do you want to change? So you want to do the opposite of whatever you're thinking, feeling, and behavior at the time. So I'm going to start with behavior. If I'm in a room full of people I don't know and I feel like, oh my gosh, I'm getting overexposed, then my behavior may be to leave. So I'm going to leave the room. My thought process may be, well, these people can stay. I don't have to stay. So therefore, I'm going to go. And my feeling is that as I change my behavior, I start to have less anxiety. So this is just a very quick and simple roadmap, but it's amazing how helpful this can be. Again, in the moment, identify thoughts, feelings, and behaviors, and then identify what you can do to change your thoughts, feelings, and behaviors, and pick one, and that's the one that you then change. Other perspectives or other things that you can do include deep breathing. A simple technique is just to simply count 1, 2, 3, and then count out 1, 2, 3 again as you breathe out. And what it does is it produces a rhythmic breathing, which actually then reduces your stress by actually over-oxygenating your muscles and making them feel warm. A more complex method is to use deep breathing, followed by either visual imagery or by using music as a way to promote feeling calm. A very complex method is deep breathing using guided imagery, where you actually then take yourself into a totally different zone or a totally different place in your mind. Now, I know we're coming up towards the end, and so I'm going to go ahead and wrap things up. And of course, you all can have a copy of this. Exercise, don't ever forget about the good effects of exercise. You can do exercise for as little as 15 minutes up to 1 to 2 hours. And the idea is we're trying to secrete endorphins. Endorphin is your natural pain reliever, but it also creates a psychological high. So in other words, it helps to bring you out of anxiety and depression. You can use your senses to stimulate, so things like taste and smell. And these are great ways to then create distraction to the brain, which then helps you to cope better. Okay, so hopefully somebody has figured out what post-COVID anxiety is. It's this. Now that the anxiety that occurs following the crisis, now that we are lifting restrictions, guess what's happening? People are now worried about, number one is, are we going to have to do the restrictions again? And number two is, if we're lifting the restrictions, how do we know that we're safe being around other people? So now again, the anxiety is being created because we don't know what the future looks like, because we're not there yet. We're only in year 2 of dealing with COVID, and we're in the after effects of that. In summary, COVID has been a very unusual event that has stirred up many negative things, thoughts and feelings, but it's also produced some positives. A pandemic is clearly something that we can get through, and many of us have gotten through it. And I congratulate everybody today who has gotten through it and hopefully has learned something. More importantly, I hope that you've learned that people matter, not things. And I hope that you understand that a support system is probably the most important thing, whether it's virtual, whether it's on the phone, or whether it's in person. Focus on everything that you've learned. Focus on what really matters to you. Control what you can control. There's lots of things in life that we can't control. Typically in life, we all experience at least one catastrophic thing in our life, and typically it's that catastrophic thing that makes our life change in some way. I hope this was very helpful for everybody. So Doreen, I'm going to kick it back to you and see if you have any questions for me.
Myself here. Oh, thank you so much. I mean, I find that so insightful, and I know working with the Brain Injury Association, I always find the brain, that fascinating and fragile combination. And it's very interesting to see how COVID affects that function, and especially the parallels with TBI. So I really thank you for that. Excuse me. Before moving on to the Q&A, I'd like to remind people that the evaluation, all the information is in the chat box. You can add a question to the chat box right here. I'm not seeing one presently, but I do have one. How would somebody who feels like they're having some long-term effects of COVID start that pathway into trying to find some help?
Yeah, it's a great question. So the first thing I would tell you is this is, primary cares tend to be the gateway. So what you want to do is talk to your primary care and explain that you're having a set of symptoms that you didn't ever have before. And if you've had COVID, then explaining that you really believe that it's connected. And that, now what we're seeing is that the primaries will refer to whomever the specialty may be. So for example, if you're more worried about the psychological effects, or you're worried that you may have neurologic effects, then obviously somebody like me, like a neuropsychologist, or a neurologist, if you're really worried about higher level things like the vestibular response or dizziness, lightheadedness, those sorts of things. So really, I would say start with the primary, because the primary can help to guide you as to what's the next step. The other thing I'll tell you is that in a lot of insurances now, because they've gotten away sometimes from things like having to have referrals, is think about the specialty that would handle the symptoms that you're experiencing. So again, if it's psychological, well, don't go to a GI doc. Instead, you want to, consult a psychologist or a psychiatrist and so on. But the easy process is primary care first.
Nice, thank you. And one of the things you did mention, exercising, and we just noticed here, because we offer yoga to our members online. And yep. I know some people of our brain injured people were very isolated, and they waited for that yoga class, even if it was just a couple of times a week, where we could come on in the beginning and the end and chat a little bit, and it gave some socialization there. And while you're doing your breathing and, stimulating the parasympathetic nervous system. So yep. It's to really calm people down. So, and it's helpful for me to even teach it. So,
absolutely.
Always. So I'm not seeing any chats at the moment. So anyone, any questions? I'll practice wait time for a couple of moments.
I couldn't have possibly said everything right.
I know. Well, we do know that I do have the PowerPoint presentation. So anyone who is interested in the PowerPoint presentation can email me, Doreen, DOREEN, @BIARI.org. Evaluations go to Richard Muto. I put that in the chat as well. But we certainly appreciate your time, and it's great to see how this has progressed from last year to this year.
That's right. That's okay. Exactly right. And who knows what will happen next year. So we'll just take it as it comes.
That's why we couldn't give long-term, because it wasn't long-term yet. So that right. Totally made sense to me. So that concludes today's session. And we thank everyone for their participation. Please visit our website at biari.org. You can also visit our YouTube channel. Oh, I have one quick, if we don't mind. I have something you said. What was the outcome with the 2 cases that you mentioned?
Ah, great. So both are actually still in progress. So the one that was in ICU for so long, she actually is progressing very well, and her cognitive functions actually were getting, she is pretty close to baseline. Which has been great. We've been using a computerized program that I use for establishing homework assignments. And then she's been coming in for cognitive therapy every 2 weeks, and has done remarkably well. She's had about 6 months of cognitive therapy in addition to daily homework assignments, and it really has made a difference for her. She is actually also being seen for the post-traumatic stress. That's actually something that's been lingering a lot more, which you would actually expect. So she will continue to be in therapy for that for, if I had to guess, probably another year or so. On the cognitive side, I would expect probably another 3 to 4 months. And then after that, then she'll be kind of ready to go, because she'll be at baseline and she'll be able to sustain at that point. The police officer that I was telling you about, her case is still very much in progress, and she unfortunately is experiencing long symptoms of COVID. So although her symptoms have improved to some degree, she still has a lot of symptoms, and it has prevented her from resuming her duties, partly because of having a vestibular deficit. She gets very dizzy, and so she can't carry a gun and she can't run. And she also gets horribly winded, because from a respiratory standpoint, she is only at about, give or take, about 60% recovered on the respiratory side. So she cannot perform her duties. So right now she's out on medical leave. She's a person who also follows up with me about every 3 weeks. She does some cognitive work, but more of it is actually psychological to keep her head in the game and to keep helping her to keep pushing through, realizing that this is going to be a long haul. It's probably going to take her the better part of about 5 years by the time we actually see everything stabilize out. Both are improving, so that's the good news. But you notice that this recovery process looks a lot like TBI, where some people can progress much more quickly and some people linger much longer. And again, it's so individualized, you just have to work with it as it happens. But great question. Thank you.
Right. Yeah. Do you have time for one quick one?
Sure.
Okay. The last one I'll do. Can you specify what your cognitive therapy entails?
Yeah, it's really a couple things. So one of the things I like using is homework. Homework helps me to look at compliance, and it also helps to keep the person engaged. And so I assign homework where they have to do it an hour per night. And what we actually use is a program called Lumosity. It is not, it's a program that anybody can use. It's not just for brain injury. The reason why I like using it is twofold. Number one is it is something that people can engage in and they don't feel threatened by it. It's also very inexpensive, which I find to be very helpful. It's about $100 for a whole year. And more importantly, what I like is I can access it remotely. So when we are doing video calls like this, I can actually be looking at their profile while we're talking. And so what they do is they give me their email and they give me their password. So I go in with them at the time, and then I pull their data up on the screen. So they're seeing it and I'm seeing it together. And what we do is we go through and we look at their strengths and weaknesses. When they have weaknesses in something, then I assign them very specific skills to work on and specific tasks in Lumosity that then focus on those skills. What we do in session is I do two things. One is as I review the homework and their compliance, and then I give them new homework. But then what we do is we work on generalizing the skills. So I ask them about how things are going day to day. Where are you finding that you're having difficulties? So if somebody says, well, my memory is not so good, then I say, okay, well, let's look at your scores. And then from there, I say, all right, so what are you doing to compensate? So how do you focus on your memory every day? And then where is it breaking down? So maybe writing lists of things doesn't work for you, but maybe putting something into your phone does. And so the whole idea with the actual interactive session is that you have to take what you're obtaining in data and then generalize it to the real world. And that's why, for example, one of the things that I don't do is I don't see patients with high frequency. I instead only see them every 2 to 3 weeks. And the reason being is this: I want life to occur. So as life is occurring and as experiences are occurring, we use that as a way to then apply the skills that we're then working on. So it brings it full circle all the time in each and every session.
It's like an ongoing assessment, which we do with education. And I personally work with the teachers that also work with students. And we're seeing the parallels between COVID symptoms and TBI.
Yes, that is
so
correct.
Wonderful.
Yeah.
We're on the same page.
Yes, absolutely.
Yes. Well, again, thank you very much. And we certainly appreciate people staying on to ask questions and listening to the answers. If you want more information, you can contact us here at the office. You can go to BIARI.org, BIARI.org. And this will also be a recorded session that will be put on our YouTube channel. You have to type out Brain Injury Association of Rhode Island in order to find our channel, but you will find it there in a few days. So wonderful. Well, enjoy the rest of your day. Thank you, everyone, for joining us.
Yeah, thank you. Thank you all for having me.
Take care.
Have a great day.